quickly a reminder of what shock is before we go on to discuss our topic for today. So shock can be defined as the clinical manifestation of failure of cellular function due to inadequate tissue perfusion and consequent cellular hypoxia, resulting from a reduction in the effective circulating volume. And it could be classified based on the etiology into hypovolemic shock, cardiogenic shock, distributive shock, which are septic shock and anaphylactic shock. We could also have obstructive shock. Our focus for today is septic shock. The concept of sepsis and septic shock has evolved over the years. This is due to advances in understanding on the underlying pathology. Sepsis is considered a clinical syndrome with varying prognosis, and septic shock is considered one of its most severe complications. Over the years, sepsis has been defined as a progressive disease which progresses from the body response to injuries, which is typically what we see in systemic inflammatory response syndrome, to sepsis, severe sepsis, septic shock, and multi-organ failure. So the terms that have been used to describe sepsis over the years have been included the systemic inflammatory response syndrome, which is an exaggerated body immune response to an insult which could be infective or traumatic. And someone is said to have this syndrome when you have two or more of these features, which include a fever of a temperature of 38 degrees or more, or hypothermia of less than 36 degrees centigrade, a heart rate of 90 beats per minute, a respiratory rate of greater than 20 cycles per minute, and a partial pressure of CO2 of less than 32 millimeters of mercury, and a white blood cell count leukocytosis of greater than 12,000 per microliter, or leukopenia, or there's increase in about 10% immature band forms. So two of these suffice to make a diagnosis of systemic inflammatory response syndrome. So that it progresses, it moves to the next phase, which is sepsis, that was defined as systemic inflammatory response syndrome with a focus of an infection, with a definite focus of an infection. Then the other concept that is severe sepsis, which was defined as sepsis with features of organ dysfunction. Then septic shock, which was defined as severe sepsis with refractory hypotension, meaning that that was the typical IV fluid intravenous fluid. Patients are not responsive to use of intravenous fluid crystalloid, requiring the use of inotropic agent. Then we have the multi-organ dysfunction syndrome, where you have two or more organ systems said to have failed. So this was the concept of sepsis and septic shock over the years. But however, as studies evolved and knowledge improved, in 2015, the study was done, revealed that a proportion of patients with sepsis did not have the systemic inflammatory response syndrome. And in some patients that had sepsis, there was no positive culture of any microorganism. So this led to a push to have a more holistic definition of sepsis that led to the historic definition in 2016 that defines sepsis as a life-threatening organ dysfunction due to dysregulated host response to an infection. I also went ahead to define septic shock as a persistent hypotension requiring vasopressors to maintain a mean arterial pressure of 65 millimeters of mercury or higher and a serum lactate level greater than 2 millimoles per liter, despite adequate volume resuscitation. And early identification is essential in its management. Sepsis and septic shock is a leading cause of death in the intensive care unit worldwide, with overall mortality of about 40%. Patients admitted into hospital with sepsis have a 10% increased risk of mortality. From data published in 2020, there were about 48.9 million cases and 11 million sepsis-related deaths worldwide, representing about 20% of all global deaths. Almost half of all the estimates of sepsis worldwide occurred in children under 5. What are the risk factors for sepsis? Some of the risk factors include age less than 10, greater than 70. For the children, their immune system is not well formed, so they are prone to sepsis, complication of sepsis shock. While for elderlies, they are immunosuppressed, malnutrition, prolonged hospitalization, immunosuppression, diabetes mellitus. Predisposing factors like from the gut could have intestinal obstruction, gangrene, perforations. We could also have peritonitis and abscess. For the biliary tract, we could have cholecystitis. For the urinary tract, we could also have a urinary tract infection, prolonged urethral catheterization. Female genital tract, there could be septic abortions, pelvic inflammatory disease. Then for vascular system, we could have a cannulae and our central line, which could be a focus of infection as well. So all these are other predisposing factors that could predispose a patient to developing sepsis. The etiology of sepsis could be bacterial, could be gram-negative or gram-positive, could be viruses, could be from fungi, parasites, could be from trauma, burns, and pancreatitis. So this is still just representing the etiopathogenesis of the etiologic factors implicated in sepsis and septic shock. So on the pathogenesis of septic shock, following an infection or injury to the body, there is an interaction between the microorganisms and the injured tissues, or the injured tissue as the case may be. Commonly, the commonest cause, about 2/3 of cases, is gram-negative sepsis. In these situations, there are molecules on the organisms called pathogen-associated molecular patterns. For the gram-negative organisms, they are the lipopolysaccharide, while for the gram-positive, they are the peptidoglycans and the lipoteichoic acid. For viruses, they are the double-stranded RNA. So these are some of the pathogen-associated molecular patterns. We also have damage-associated molecular patterns. This occurs a lot of severe trauma. So following any of these events, infection or trauma, there is an interaction between these, either the pathogen-associated molecular patterns or the damage-associated molecular patterns. They activate the immune cells via a toll-like receptor on the membrane of these immune cells. These immune cells include the monocyte, the resident macrophages, dendritic cells, neutrophils, and sometimes even the endothelium. So this interaction between the immune cells and the toll-like receptors on their membrane with the living organism or insult leads to transcription of genes that eventually leads to production of pro-inflammatory cytokines. Of note are the tumor necrosis factor alpha and interleukin-1. These pro-inflammatory cytokines further activate the inflammation response with an intent to localize the insult or injury or the infection. After about 1 to 2 hours, the level of these pro-inflammatory cytokines drop, and there is increase in anti-inflammatory cytokines like interleukin-4 and interleukin-10. The whole essence is to achieve a balance between the effects of the pro and anti-inflammatory cytokines in curtailing an insult. However, there are situations where this response may be exaggerated, where there is a sustained release of the pro-inflammatory cytokines. This leads to the spillage of these cytokines into the general systemic circulation in an attempt to still recruit more immunocompetent cells to the site of injury to still wall off or curtail this infection. This sustained high level of pro-inflammatory cytokines is the basis of what happens in septic shock. So the tumor necrosis factor alpha that has been released into the circulation have several effects. It actually affects virtually all body organs. The hypothalamus, it causes an upregulation of the hypothalamic set point. This leads to pyrexia and see in patients with sepsis. It also binds to endothelial cells, causes injuries to the endothelial cells. So following all the events that happen, the effect of the tumor necrosis factor, which is a bedrock of this, it eventually leads to features such as we see in shock that may affect all body systems. For instance, in the respiratory system, the respiratory distress, acute respiratory distress syndrome, the cardiovascular system, depression of the cardiovascular function, acute kidney injuries, in the hematologic system, which may be in form of DICs. There could also be bone marrow suppression. Hepatic dysfunction may present as derangement in bilirubin concentrations, and patient may present with jaundice as well. Also in the CNS, it also causes septic encephalopathy. Patient may present with altered sensorium. GIT. The GIT is one of the systems that is compensating for the hypovolemia in shock, leading to ischemic necrosis of the mucosal layer, which further leads to translocation of microorganisms into the general circulation, worsening the system. The hyperglycemia, this is as a result of insulin resistance in the patients with sepsis. And overall, there is reduced utilization of oxygen at the tissue level. So commonly, the patient may present with fever, tachycardia, hypotension, tachypnea, and features of organ dysfunction. The patient may be oliguric, may be with respiratory insufficiency, altered sensory, maybe jaundice as well. So we said earlier on that in sepsis, there is a dysfunction in the organ system. So an adopted way of assessing the dysfunction in sepsis is the sequential organ failure assessment, which is otherwise called SOFA. It assesses the respiratory system, coagulation system, the liver, the central nervous system, the renal system. And each of these systems is scored on 0 to 4 points, and a point of 2 or more confirms the presence of sepsis, as well as it can also be used in prognostication of patients with sepsis. Some of the investigations we want to do for a patient with sepsis or septic shock will include a full blood count, which may show a leukocytosis or leukopenia. There may also be thrombocytopenia. The serum electrolyte, urea, and creatinine may be deranged. The liver function test as well may also be deranged. Coagulation studies may have derangements in the PT and activated partial tropoplastine time, as well as the INR. Arterial blood gas may show acidosis and hypoxemia. We also may want to measure lactate, which is expected to be less than 2, but in shock, it's usually greater than 2 millimoles. We also want to do a chest X-ray. We said earlier on the other predisposing factor in the respiratory cell, like pneumonia. We want to do a chest X-ray, which may help in identifying the focus of the infection. We also want to do an abdominopelvic ultrasound or CT scan to identify any intra-abdominal collection. So sepsis and septic shock are medical emergencies, and it is recommended that treatment and resuscitation begin immediately. The goals are to restore intravascular volume, increased oxygen delivery to tissues, and reverse organ dysfunction. And in achieving this, there was a consensus, which is referred to as the Surviving Sepsis Campaign. It's a consensus initiated to reduce the morbidity and mortality of patients with sepsis and septic shock. It has bundles. It has 2 bundles that should be achieved within the first 3 hours and 6 hours of presentation. The whole aim is to early identification, early IV fluid administration, early antibiotics administration, and early source control. In management of a patient with sepsis, according to the Surviving Sepsis Campaign, begins with resuscitation. You want to do the ABC of resuscitation. You want to ensure that the patient's airway is patent and the patient is breathing. The patient may also require ICU admission, and ventilation. The first bundle should be achieved within the first 3 hours. It involves measurement of the lactate, collection of samples for blood culture, following which broad spectrum antibiotics are given. Commonly in our environment, we want to give the 3rd generation cephalosporin, as well as a medication to cover for anaerobic dimetrodid as well. And you want to give intravenous fluid at the rate of 30 ml per kg over 3 hours. This should be done within the first 3 hours of presentation. Then, within the second bundle that should be done within 6 hours, for patients that are not responding to IV fluid, we want to give vasopressors. The first line vasopressor usually is noradrenaline at a dose of 8 to 13 micrograms per minute. This is titrated to desired blood pressure. Other vasopressors that may be used as indicated include vasopressin as well. In the 6 hours, we also want to measure central venous pressure. You want to measure central venous saturation, and as well as measure the lactate level. Now, all these are done to ensure good outcome in the patient. So what are the endpoints in this patient being managed for sepsis? What do you want to achieve in our resuscitation in this patient? You want to achieve at least a mean arterial blood pressure of at least 65 millimeters of mercury, urine output of at least 0.5 ml per kg per hour. You want the central venous pressure to be at least 8 millimeters of mercury, the central venous oxygen saturation to be at least 70%, and you want the lactate level to be less than 2 millimoles. So this is just still going through the definitive treatment. It involves IV fluid, and this is not just based on the 30 ml per kg, but also dependent on the patient's response. More fluid may be given where necessary. You want to initiate oxygen therapy as much as possible to maintain oxygen saturation at least 92%. You want to give broad spectrum antibiotics, as said earlier on, and this is usually done. Initially, blood cultures are taken, then commence spectrum antibiotics. Once culture result is obtained, the antibiotic will be changed to the sensitivity pattern. Then the use of vasopressors, as earlier said. Then there is also the place of use of steroids. This is commonly for patients that may have not responded to fluid and the vasopressors. Steroids are indicated. They are said to reduce the production of the secondary mediators of inflammation. They inhibit the breakdown of membrane lipolipids, forming the arachidonic metabolites. They are also believed to increase intravascular fluid volume and improve the response to vasopressins. We could also give antioxidants in the form of vitamin C, vitamin E. This helps to reduce tissue damage. Insulin therapy is also recommended. Most of the patients may present with hyperglycemia. The blood sugar is recommended to be at less than 10 millimoles per liter. Where necessary, we want to transfuse the patient with blood and maintain a blood pathway volume of at least 30%. For patients that may have heart and cardiac depressions, we want to give an inotropic agent like dobutamine. Then source control. Some of these patients may have septic foci. I want to address those. For patients that have gangrenes in the extremities, we want to do debridement. Where necessary, we need to do adaptation. For those that have peritoneal collections, we want to drain. We want to manage the organ failure. For patients that have come down with renal failure, we want to do dialysis for them. For those that are presenting with DIC, we want to provide them fresh frozen plasma as well and manage the situation. Then for those with acute respiratory distress, they want to admit in the ICU, intubate and ventilate as well. So some of the recent advances in the management of sepsis and sepsis shock include the use of immune modulators. The bedrock of sepsis and septic shock is a derangement in an immune response. So studies have been geared towards finding a way of manipulating the immune response. Some of these methods will include the anti-endotoxin antibodies, anti-cytokine antibodies, and anti-tumor necrosis factor and anti-interleukin-1. We also have cytokine receptor antagonists. We also have nitric oxide synthase inhibitor, also oxygen radical scavengers. However, outcome has not been very encouraging. There's still a lot of studies ongoing with them, these advances. The prognosis, mortality is quoted to be around 20 to 50%, with poor prognostic factors to include advanced age, as mentioned earlier on, infection with a resistant organism, impaired host immune status, poor prior functional status, continued need for vasopressor for more than 24 hours. These are indicators of poor prognosis, and development of sequential organ failure despite adequate supportive measures and antimicrobial therapy. So in conclusion, septic shock is an emergency with high mortality. Early identification with prompt intervention is essential to achieve good outcome. These are my references. Thank you.
How does trauma lead to septic shock?
Trauma causes the non-septic pathway of septic shock. And there is trauma, which could be trauma of surgery, burns, or any form of injury. Then there's tissue damage, and then this tissue damage is what stimulates the inflammatory responses of which pro-inflammatory cytokines, interleukin, 1 alpha and 2 necrotic factor are released in the first 1 hour, and in the 3 to 4 hours. We will now mobilize the white cells, which will in turn produce the anti-inflammatory cytokines that will get to the site of the injury. Unfortunately, when they could enter the blood and go into the circulation, and then there will be widespread reactions from all tissues, and that's how septic shock will eventually occur with a lot of further factors coming.
Okay, well, I was expecting to hear certain molecular patterns. Yes, I know you mentioned them, but I think you should have damage-associated molecular pattern as against infections that comes with pathogen-associated molecular pattern. Both of them, yes, okay. They activate the toll-like receptors, which would then lead to a myriad of cascade that now lead to septic shock.
Tumor necrosis factor can trigger the synthesis of those phospholipid than arachidonic acid that will now further cause formation of prostaglandins, platelet-activated factors, and prostacyclin. So those are the ones that will go further now cause. In a trauma patient, few days post-trauma, how do we differentiate septic shock from hypovolemic shock or hemorrhagic shock? For septic shock to happen, they have to be tested, they have to be focused on infection. You understand? Then for hemorrhagic shock, a patient is bleeding. So both of them are going to eventually end up having shock. So for us to be able to differentiate that this is septic shock and not hemorrhagic shock, or this is hemorrhagic shock, not the septic shock, we have to look at mean arterial pressure. This is greater than 5 millimeters of mercury. Mean arterial pressure. Serum lactate, which you also spoke about. Serum lactate marker to identify hypoperfusion that happens in tissue. He mentioned the value, I think he said greater than 2 millimoles.
In hypovolemic shock, so if it's not greater than 4, you repeat the serum lactate in another 4 hours to check if at that time it's going to now be reduced or not. So if you have normal serum lactate, you repeat your serum lactate after about 4 hours, 4 to 6 hours to check the value. Not that if it's normal, it's not a septic shock or it's no. For all forms of shock, it's always increased.
Septic shock can be a common pathway for all forms of shock. So, but I think, yes, patient that's had trauma is more likely he will have hemorrhagic shock than septic shock. But in the later end, it can lead to septic shock. The mean arterial blood pressure in all of them would be less than 65 millimeters of mercury, irrespective, of the shock. And then I think you should have also talked about the differences in terms of pulse rates in hemorrhagic shock in the grade 2, grade 3, and grade 4. In grade 1, you just reduced pulse pressure. So you might just have mild tachycardia, or you may not even have any differences in the pulse rate. Septic shock in most times will give you bradycardia. Most of the time will give you bradycardia, as against hemorrhagic shock that you have tachycardia, especially from grade 2 and above, class 2 and above, I mean.
With hemorrhagic shock, in your trauma, so when you examine them, most likely in the early phase, the pulse will likely be rapid and thready. Unlike in septic shock, because in septic shock there is increased cardiac output, so most time the pulse is bounding. Then on the extremity, or hypovolemic shock, you have cold clammy extremities.
Fantastic.
Whereas for shock, in the initial phase, they are warm because there is pooling of blood in the periphery, so the extremities feel warm. So these are some other ways, in addition to other things they've said. But even in the septic shock, towards the end, when there is cardiac depressions, even all the pulse become very faint. Then there is louder cold clammy extremity. But generally, you can also use this to differentiate them as well.
The 66 bundle. These are some of the standardized ways of anticipating or reviewing shock with the aim of activating an emergency team. So, the first is 66 bundle. This involves 6 tasks that should be completed within the first 1 hour of receiving a septic patient. This is you commence oxygen, you take cultures, blood cultures, urine cultures, wound swabs, or whatever septic focus you may find. Then IV fluids must be commenced, broad spectrum antibiotics, the lactate should be checked, and urine monitoring should also be instituted. The next one is the early warning score. Early warning score is something we are supposed to use in the ward. As the name implies, it's an early warning that the patient is decompensating.
Are we even supposed to manage a patient with septic shock in the ward? Most current texts will tell you those patients should be managed in an intensive care unit, because you also want to control further source of infection. You want to control the environment where you can, manage this patient and intensively monitor the vital signs. Well, look at Schwartz. Schwartz mentioned you move them to the intensive care unit.
For early warning score, it's like the patient will be managed. It's more like an early warning to decompensation in that patient. Now, this includes the vital signs such as the respiratory rate, temperature, pulse rate, oxygen saturation, and the blood pressure. and the ECVPU response of the patient.
You've talked about the use of 30 ml per kg. You are faced with a 70 kg man. How will you manage this patient who has septic shock? Practically, 70 kg man in a trauma or in A&E with septic shock. How will you manage this patient? Practically.
Based on the survival sepsis campaign, for this patient, I want to commence resuscitation. I want to ensure that the airway is patent. I also ensure that breathing continuously, and where they be, I want to intervene. Maybe admit the patient into the ICU, intubate and ventilate the patient. Then in the first, the sepsis bundle, which used to be 2, but now it's 6 that should be done in 1 hour.
What do you typically do? I thought usually you give a bolus of 1 liter of normal saline.
Yes,
exactly.
You give a bolus of normal saline within over 30 to 45 minutes and reassess. When you do that, you want to reassess the pulse rate in every 15 minutes. You want to, as you give, you want to auscultate the base of the lungs as well. But before they want to pass a urethral catheter for the patient and empty the bladder.
Fantastic. So it is in children that you give those anti-shock regimen of 30 ml per kg. In adults, we don't really follow that 30 ml. Children, yes, anti-shock. You want to give your anti-shock regimen and then quickly reassess. And then subsequent fluids will depend on the hemodynamic parameters.
Some things that we don't have in place, we don't see regularly here, should also not be left out of our management of the septic shock. When you talk of the ICU monitoring, those arterial invasive actions that we take in ICU, we should remember them. Schwanger's catheters, how are they located?
Fixed stopper, which is actually easier for we all, because for the sofa score itself, you have to do with lots of investigations. But for fixed stopper, it's more of clinical evaluation of the patient, and just 3 things you need, which is patient mental status, respiratory rate, and also the blood pressure. So when you see it's better than 22, BP, circulating blood volume, blood pressure less than 100, or the endpoint of resuscitation, we classify into systemic, specific, and also cellular. So for your systemic, so your lactate, your base deficit, your cardiac output, oxygen saturation, and the like. When it comes to tissue specific, that's when I come to practice about things like gastric tonometry, then tissue pH, your near infrared spectrometry. You get the chance to look at them. Then when it comes to then cellular, in terms of membrane potential and also adenosine triphosphate, so you look at it both systemic, tissue specific, and also cellular and cell specific for the patient, based on what you have, actually what you can actually do. Because we basically just use clinical, which is more of just systemic, looking at blood pressure, the pulse rate, urine output. That's what we actually basically do. But of course, we're not doing what's actually right, because those other things will give you real-time information about the patient, unlike just looking at the patient clinically.
30 ml per kg. Just as we have all these fluids, all these things are guides. So in your mind, you should know that before the end of 3 hours, this patient should have gotten at least, so if it's an adult, that's 2.1 liters. Let's remember that in septic shock, there's vasodilatation. So the patient needs a lot of fluid. Because of that vasodilatation, you have fluid leak. It will be even difficult to even maintain, to improve the intravascular volume. That's why I see that eventually you now need to even use the vasopressors, adrenaline, and distinguishing the septic from hemorrhagic. Anytime we're answering all this, let's remember and try to be hemorrhagic shock. You would have had a history story, you would have gotten a history of either a blunt abdominal injury or an open injury with obvious blood loss. They would have given you a history of cardiovascular collapse there. So, or you see a patient that is bleeding out. So that will give a pointer. So when you start painting your history, you'll be painting that from history. You go to examination, everything we've said, and then investigate all those adjuncts like serum, lactate, examination in the septic shock, the stimulatives in the hypovolemic shock, focus of infection, fever will also be there for the septic shock compared to the hypovolemic. If you follow it that way, then you would not miss it.
The sepsis things we're talking about, it's important to note that the code for it is give 3, take 3. You're giving oxygen, you're giving fluid, and you're giving antibiotics. More like a code. Then you're taking 3. You want to take sample for serum lactate, you want to take sample for blood pressure. You want to take urine.
I'll soon be done with the meeting.
In your presentation, it's important when presenting like this, you also include monitoring of the patient. Because usually, following your resuscitation, you need to monitor. It's when you monitor, you want to know whether the patient is actually doing well, you're actually winning. So it's important. So, and the ideal place to manage, as we mentioned, at least it has to be high dependency units, even if the ICU is full. Quick so far. Just look at those 3 things: systolic pressure, the respiratory rate, and the alternation.
Questions for the group. I think sometimes microbiology residents rotate through our surgical postings, isn't it? I want to suggest, if for any reason there's any microbiology resident that is currently rotating through the department, and there's going to be a topic like this, or even if there's not going to be a topic like this, something can be created. A topic like this can be created for presentation, so that microbiology resident can present, or somebody else can present, and then that microbiology resident, because most times they're senior residents, isn't it? They can actually moderate this kind of presentation. I think it will be more practical, because since they're involved in the management of patients that have sepsis. We have quite a lot of these kinds of patients, especially in the ICU. I think only just yesterday we were discussing one of our patients in ICU that had passed on yesterday, and it was because patient had developed septic shock. It will also be more practical, because I think even in the collection of the blood cultures, I think there's even a process, isn't it? There's a process, the way they clean the skin, what kind of agent that is used to clean the skin and the rest. So I think it will be more all-encompassing. If you have surgical residents that are passing through the department, we can make good use of them by assigning topics to them or telling them to moderate, and then I think the discussion will be more enriched.